So I want to test my speaker. I'm gonna press mute on the device. Let me know if you can hear me.
Okay.
Okay, I guess you're not hearing me.
Nope, I do
So
not hear
yeah,
you.
I have it has this button, so I'm just trying to see like the muting on the screen or the on the thing.
I think both of them work. If I remember right, you kind
Yeah.
of double muted, so you'd have to unmute in two places if you use the button.
Yeah.
But yeah, feel free to use that. I always tell people you can use that if you have a coughing bout or whatever, need a drink of water quick, you can always use that. The other thing too, just you reminded me, is make sure your pager is turned off. And if you have a phone, to silence that. All right, it looks like we're at the top of the hour here. Do you want to switch back to that opening slide and I will start the webinar? All right, you're all set, Martha? Oh, I can't hear you if you're talking.
Oh, yes, I am. All
Okay.
set.
All right, sounds good. Here we go. Hello, everyone. Welcome to today's bonus phlebotomy webinar on phlebotomy COVID-19 process. This is Heidi Zunker, an Education Program Manager for Mayo Clinic Laboratories. Our presenter today is Martha Yiglatu, an Assistant Supervisor in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function or the Q&A icon on Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn things over to our presenter.
Thank you, Heidi, for your introduction. Today, I'll be discussing COVID-19 process and how Mayo's inpatient lab services responds to the crisis. I don't have any financial disclosure for this presentation, and also I'm not discussing any off-label usage. So COVID affects everybody at all level, and we, as the inpatient lab services working here at Mayo, we responded to the crisis accordingly based on the information we have on hand. So today I'll be discussing that during my presentation. We will discuss staff training and modified droplet precautions, field testing, and proper use of N95 or PARP and face shields. We will review the unique needs of the different services area to address the PPE preservation and collection process. We will describe changes to blood draw processes to minimize the need to enter COVID-19 rooms. We will identify the adaptations that need to be integrated into the blood collection process to facilitate collaboration between nursing and phlebotomy staff. So in general, blood collection process requires the phlebotomist to be in close contact for 3 to 7 minutes with a patient. And sometimes during difficult collection, the phlebotomist is required to be in the patient room in a close contact for longer time. according to CDC defines close contact being within 6 feet of a person with COVID-19 positive for a prolonged period of time, or having unprotected direct contact with infectious secretion of the patient. So in general, we assume all patients are potentially infectious. So we always remind our staff to follow the institution's infectious control guideline to minimize potential exposure and infectious spread prevention. Sorry. So working in a ever-changing healthcare environment, we require our phlebotomists to have the ability to adapt change, because there will be a lot of innovations, a lot of change with technology, the way we manage healthcare, and with that scope, having the skill set to adapt to any change is one of the requirements for a phlebotomist. And most of all, we require all our phlebotomists to remain calm at all times. So the assumption that all patients are potentially infectious is also translated to the pandemic situation. And we assume all patients are potentially infectious of coronavirus. Since situations were extremely fluid at the beginning, just to give you an example, when we heard about this virus, the way we were handling our patient would be in a precaution room. At the beginning, it was airborne, and the more we learn about the virus, we switch it to modified airborne, and again, we learn more about it. We switch it to modified droplet. So with that ever changing, with that continuously changing situations, we need to understand the risk and implement the most appropriate precaution. What are the recommendations out there for our staff, and what is CDC recommendation for the coronavirus exposure and spread prevention for the healthcare workers? CDC recommended to have close masking in public when we cannot maintain that social distance. How that is translated in the healthcare environment, where with the service provider need to be in a very close contact with the patient. What is the Mayo Institution guideline? Mayo require everyone to be so Mayo screens everybody who's entering our building for symptoms. We have people by the door checking temperature, asking questions to ensure that those visitors and employees are safe to enter the building. And every patient get tested for COVID-19 before or at admission. Still, there were a lot of fear, and it wasn't as simple as applying standard precaution like hand hygiene, PPE. We need to ensure that our staff have the appropriate PPE to protect themselves, our patients, their colleagues, and everyone. So PPE shortage has been a global issue, and how are we addressing this PPE shortage matters. Devising PPE preservation and efficient utilization also part of this process. Thinking differently, like creatively, to address PPE shortage. For example, here at Mayo, we use different technology to print a face shield, so our staff will have enough supplies. And it is a difficult, like I said earlier, it's difficult to maintain that 6 feet during blood collection. So do we need to modify our process to minimize the exposure? And what is our chain of command? Who do our phlebotomists listen to? Where is that information coming from? Who's in charge of whom, and whom permission must be asked? The goal is to assess where we are. Do we need to modify plans to ensure staff and patient safety, to have to have the correct skill set for the patient care area. So how does the inpatient phlebotomy address the issue and make changes to minimize risk in a timely manner? Inpatient lab services is an inpatient phlebotomy that provides service for different areas in the hospital, like all inpatient in the hospital and also some hospital-based outpatient areas. The goal is, like I said in the previous slide, to assess where we are. Do we need to modify plans to ensure staff and patient safety, to have the correct skill set for the patient care area with a timely response? When our leadership and education team were working on the process change, we considered the situation from all angles possible. Our phlebotomists are expected to different uh, they are exposed to different patients who are not well, and staff felt they were being at risk. There need to be an aggressive education campaign to allay those fears. Whether the fear is unfounded or not, they are real. So the leadership need to implement a process to take their fears into consideration and making staff feel they are fully protected. So just to give you a background about the inpatient lab services, we have approximately 270 phlebotomists. We are 24/7 service providers. Phlebotomy service, we have phlebotomy services at both our Rochester campuses, the St. Mary's and Methodist hospitals. We provide service in the general service area, in the emergency department, intensive care units, the neonatal intensive care units, pediatrics, and hospital-based outpatient areas, and occasionally other outpatient areas as needed. Our phlebotomists are required to have a variety of skill sets. So they know how to do vein puncture, arterial puncture, line collection from both arterial and venous lines, and capillary collections and point of care testing. We perform point of care glucose and eye stats, and also for how our highly skilled techs, they will be trained on the IV placement, and also they are required to know how to respond to emergency situations such as medical course, rapid response, traumas, based on their skill sets. So how did we respond to this crisis? We implemented the following 7 responses. This is a different situation. There were fears, not only among our phlebotomists, also among other patient care staff. Our safe practice may not seem safe for someone from other area who's not familiarized with our process. So we educate our staff on the proper chain of command, so they know how to respond to situations like someone doubting their practice, and we establish the decision-making chain is very important, especially when there is an overwhelming of information, when everything is difficult to decipher. Communication is vital, and we need to provide accurate and up-to-date information to our staff. And it's critical because the decision at institution, department, work unit level affects the nature of the job. And this may require us to modify our process. We need to ensure the directives are coming from the right chain of command. Our phlebotomists follow the proper chain of command, which help us to identify gaps in practices and procedures, and which help us to able to um, bring change based on the gaps that have been identified in the process. We provide instruction to staff on how to interpret door signage, what PPE equipment can they use before they entering into the patient room, or making sure resources are available for them, or guide them where to find when equipment is not available by the patient door or on that specific floor. Another one we did was fit testing as a part of PPE conservation and utilization. We also limit the number of times a phlebotomist entering a COVID-19 patient room, and preparing and empowering our staff to have the skill sets and confidence to provide service to our COVID-19 patients. We increase our staff training so to correspond the need of our patient, because if one of our staff is suspected for potential exposure, or if they show symptoms, our occupational health will tell them to quarantine for 3 days or up to 14 days. So that will take away our staff. So in order to mitigate that gap, what we did was we are increase our staff training. So I will be going through each strategies, response strategies we use for this process. One of them is the communication and update, and there is a chain of command for communication and update at all levels, from institution, department, division, and work unit. In time of chaos, it's important for everyone to come together to make sure that staff able to get the information from one area. Where our staff getting this information, and what is the current patient population, which area of the hospital is receiving COVID positive patients. All these were the questions that were asked at that time. And our leadership, the Mayo leadership team, they created this COVID-19 information center, which is available in the Mayo homepage, so it will be accessible for all the staff. Like you see here in a yellow banner, as the yellow's bright, so it's visible for someone to see, so they know they can go there and they will get all the information you need. What to do if they feel they are exposed to a COVID-19 patient, or if they feel there's a breach, and if they want to learn more about it, and almost all the current information will be plugged in into that homepage. The other one is HICS, which is the Healthcare Incident Command System. Our operational manager was part of this leadership team, which is activated only when an emergency situation surpasses, or if there is an anticipation to surpass the normal operating capabilities of the institution or the department. So during this pandemic, HEX was activated, and we get, when HEX is activated, a take over to provide directive and instruction to healthcare workers in our institution to make sure that everybody's on the same page. The phlebotomist leadership plays a major role, because our phlebotomists rely on their leadership and management for guidance, resource, and support. So phlebotomists are adaptable to change. So with that, it's the responsibility of the management and the leadership team to provide the necessary training, information, resource, and support. And patient phlebotomy leadership provide job-specific information and reinforce compliance of institution guideline. We have meetings almost every day, and then we provide, based on that discussion from our meetings, we provide daily update to our staff, and we support them. We have presence on the floor where our staffs are, because our staffs are located in different areas in the building. So we go there, we make sure that to ensuring them that we all are in this together. And our management, education specialist, and quality specialist team, they make sure that all documents are up to date, and not only for us, and also for other areas with whom we are collaborating. So our expectation is our phlebotomists to follow general guideline and wear PPE as indicated in our institution guideline, and also to follow the door signage, so they know they have the proper PPE before they enter into this patient room. Mayo tests all patients for COVID-19. Until the result comes back negative, patients will be placed under the modified isolation precaution rooms. These are some of the different door cards we use. We have the anaerobic precaution, we have the droplet precaution, which we use it for regular influenza and other respiratory. And then we have the PPE required, this lime green one, if patient is under aerosol generating procedure, and if there's a procedure going on that nobody should be getting into the patient room, and we put this red card by the door. And then for our COVID positive or COVID suspected patients, we put this modified droplet precaution card, so our staff will know how to prepare themselves before they go in. So our expected general practice are, we require everyone to follow the universal masking guideline, wear eye shield, perform hand hygiene frequently, hand washing or using the hand sanitizers. We expect that to happen all the time, regardless of the patient area. And for non-COVID-19 patients, we require our staff to wear the mask, a surgical mask, and wear eye shield, in addition to following universal precaution, the glove and hand hygiene. We are very strong on our hand hygiene process, because as our staff going from patient room to patient room, we need to make sure that the equipment they're using, and also their before, in order to prevent contamination, we put in a very specific hand hygiene process for them, which they will get trained the moment they join our department. And gloves, we consider you have a gloves, that means your hand is dirty. We that help us to emphasize whenever they take off the gloves, so they can do hand hygiene before they touch their supplies. So not all COVID-19 patients require N95 and PARP, based on our current knowledge of how this virus is spread. Staff are trained to follow door signage to get information on the required PPE. So for modified droplet precaution, which is for the COVID-19 positive patient or COVID-19 suspected patient, our requirement is to just wear a surgical mask and a face shield, not eye shield, but a face shield. And that is because our infectious control and our medical leadership team, they found out that our staff was safe as long as they wear the face shield and also the surgical mask for this COVID positive patients room. And so for patients who are on a high risk of aerosol generating procedure, or also who are also COVID positive and also receiving higher risk of aerosol generating procedure, we require our staff to wear N95 no matter what. And so this is where this door signage will come in place to make sure that our staff are protecting themselves, and also protecting their colleagues and their families. So So when it's safe for our staff to get in, we always recommend for our staff to communicate with the nurses, because the nurses know more about the patient, and how the situations are. And we, like I said earlier, we also require them to follow the door signage and determine if it's safe for them to enter into the patient room. And then they should wear proper PPE the uh, based on their signage. And because at that time, some supplies like the popper and N95 were in shortage, we need to make sure that we know we're not just wasting N95 by going to the patient room that do not require N95. So that guideline come like, so when do the staff they must wear N95 and face shield. That is when a patient is under modified droplet precaution, and also they're having aerosol generating procedure, and that aerosol generating procedure could be a high or a medium procedure. And for a low aerosol generating procedure is not required. And this aerosol generating procedures can happen anywhere in a hospital. So there is not limited to certain areas of services in the hospital. Like I said earlier, for patients who are under the modified droplet precaution, we just wear surgical mask and face shield. Um, the another strategy we implemented was training our staff on proper PPE, done on and off, and we provide them hands-on refreshment training. This training was set up by our infectious control team and nursing team for inpatient multidisciplinary healthcare workers who are providing direct bedside patient care for the COVID-19 patients. This is just to enhance their current knowledge and to ensure that they know how to properly don on this PPEs before they go in, and also how to dispose them properly before they go out. And also we provide them pictorial everywhere where this patients, the COVID positive patients are, so they will have that reminder all the time. And in addition, we also train them on PPE conservation. What you see in this picture is this is our PPE storage room for recycling and reusing purpose, and we provide the training how to decontaminate uh, their face shield, and how to decontaminate their N95 container, and when to reuse the N95 and when to dispose them, and how to recycling the N95 and the face shield, and how to store them. We give them detailed training on this processes. Um, Before COVID, there's no need for inpatient lab services to be uh, to send the staff for fit testing. That is because we have a very large number of staff, 270, and also they are on a part-time and full-time basis, and there was no need for it in general. But when COVID hit, and due to a shortage for paper and paper hood supply, uh, and then to preserve PPE, it became ideal for us to fit test all our staff. So within 3 weeks, we, in collaboration with safety, and who are kindly give us a flexibility of time and location for the training, we fit tested more than 260 phlebotomists in 3 weeks. All of them, they have to pass the medical clearance, whether they are okay for N95 or the PAPR. And those who passed the fit test, they will wear N95. And those who could not pass the fit testing or who had a personal reason to not to wear N95, we make the accommodation to address the concern so they can wear a PAPR. So we need to have a safe and effective process to minimize the chance of exposure by reducing frequency of the entry to the COVID positive patient room or those receiving continuous aerosol generating procedure. It's known that the virus is transmitted via droplets. Based on the current process at that time, we assessed the patient's population, opportunities for coordination with other patient care areas. We collaborated with the nursing to take over collection, blood collection. No, not all areas of the nursing will provide one-to-one patient care. So we have to put that in mind too when we were looking at how we can reduce the how we can reduce for our phlebotomists to enter the number of times they will be entering to this COVID positive patient. So we identified the service need and the ability to take over collection for each area, like for the general floor, the ICUs, the emergency department, and also our neonatal intensive care unit. We facilitated training on meters and instruction training materials to provide to our staff and also for our nursing staff. And then we looked at also even considered when we do patient ID, how can we make sure that our staff can do patient ID when we do this, when we do collection, if we are giving the nursing staff the most of the blood draw collection. And then also we identify what they can do because we don't want to interfere with their ability to care for the patient. So which part of the collection process they can do, which they cannot do. So in the ICUs, the nurses will do online draws, the arterial line and venous line collection, and we do a lot of point of care glucose testing. We have Q15, Q30, Q1s. This point of care glucose testing used to make us to go in frequently in the same patient room, for that matter. And then we also perform IV placement. So what we did is in collaboration with the nursing, the leadership and education team, we give away those collection processes to the nursing staff. And in the ED, the current process, the process pre-COVID was for traumas, and they perform IV start and we draw blood from IV start or existing IVs. So we maintain the same, but we change the process. We modify the process a little bit so it can work the same for the nursing staff and also for our techs. So based on this, identifying the service need and of each area and also what can be done, our education team, in collaboration with the nursing education team, we developed the process flow and we provided training for nursing staff and also the inpatient lab phlebotomists. And for the point of care testing, we coordinate that with the point of care coordinators to make sure that the nursing staff, all of them, will be trained to the standard and to ensure that they can continue to provide the service. So our ICU RN collection process for our modified droplet precautions, the criteria is patient is in a aerosol generating procedure, because the patients will be on ventilators and different respirators. Those respirators may have filters or not, and based on how they are set up, they can be categorized as a high risk, medium, and low. So if the patient is at high risk aerosol generating procedure, that will automatically put them to require N95. And for if the patient is receiving the middle high the aerosol generating procedure, and the patient must be suspected of COVID-19, or the patient must be COVID-19 positive, which automatically will put them in this category. So, and then another one is patient must have a line. It could be venous line or arterial line, because that's where how we train our nursing staff to collect blood from patients. And the overall collection should be simple, not complex. So when our phlebotomist arrive to this patient room, they will communicate with the RN through the glass door, because in the ED and in the ICU area, we have our ICU doors are glass doors. So it will make it easier for the communication. And there will be the patient wristband will be by the patient's door, and our staff will scan it into the ELIS system. They will pull the orders, they will print labels, and pre-label all the collection tubes, and pre-assemble all the collection device, and they put it in a blue container like you see here. And also for the collection devices, we try to make it as sterile as possible. And we also prepared a card for the nursing staff once they collect the blood, to show how many times each tube require inversion. So we put that in the blue transport container, and if the patient has an anteroom, our staff will go to the anteroom, and there will be another blue container. They put it there without touching. Or if the patient is in a non-anteroom, the RN will meet the staff by the door, and they will dump the collection device into another transport container that the nurse is holding outside. Once the nurse performed the collection, and they will wipe the bag that was, they put the specimen in the bio bags, and they will wipe the bio bags with Oxivir, and then they put it back in the blue container. Either they wait by the door if it's in an anteroom, or they will uh, place it in the anteroom for our staff to go pick it up. So for the ED RN collection process, the criteria is for blood collection would be from IV start or from an existing IV, and patients should be on aerosol generating procedure, either high or medium risk, and this will also include our trauma, pediatrics, and difficult vein punctures. So because in the ED, when you draw labs from IV start and from existing IV, you have to use a syringe system. But in the ICUs, because they draw it from in the ICU, we train the nursing staff to do it from the both ways, because on the peak we cannot use the vacutainer system. So for that, we train them to use the syringe system. But mostly for arterial collection or any venous line collection other than PICC line, we encourage them to use the vacutainer system, which will provide us a quality sample. So in the ED, we set up our supplies and label our syringe accordingly to so the nurses can draw from the IV start or existing IV. Again, the patient wristband will be hung outside. Our techs will scan the wristband, pull the order, and verify patient the label with uh, the ID band on the door. And again, we use the transport container system, and without touching, they will transfer the supplies into the transport container. Again, we use the same anteroom versus non-anteroom process that we use for in the ICUs here in the ED process too. But now, recently, we changed the usage of the transport container. Instead, the nursing will put the blood in a bio bag. They will wipe it and they will just hand it to the techs, and that become an approved process now. So when it's safe for lab services tech or inpatient phlebotomist to draw a blood, we're not giving away all of our blood collection process to nursing. We are still required to do all venipuncture and arterial punctures for the entire hospitals. During an RN collection process, if the collection become difficult or complicated, which means the draw was slow and we need to go in and assist with the transferring of the blood into the tube immediately, or it's not drawing very well, so we need to minimize or micro the blood. So our techs will have to go in and then assist with that transferring of the blood and make sure that we have enough blood for all the tests that's ordered. Or if the patients are in a special group, especially our ECMO patients, our phlebotomist will do the collection. And then our phlebotomists collect all blood collection in all general areas, whether they are COVID positive or not. We follow, again, the door signage. It was very important because it was a cue for us to see what PPE we need to done before we go into the patient room. We require universal masking, eye shield or gloves all the time in all direct patient care areas. We also set up a communication system for the staff to report any process deviation, such as PPE breach. And also in our training, especially in this general area, then our staff will see a different signage. It's just could be just that modified droplet precaution, or it could be just only the PPE required this green line card, or it could be a combination of the modified droplet and the PPE required together. So we train them how to interpret this different door signage and how they make sure that they have enough the resources they need in the area before they go into the patient room. So staffs are required to take their temperature twice a day when reporting to work, and this is for Mayo-wide. We even give out thermometers for our staff so they can check their temperature before they come to work, and then twice a day in general. So that is to make sure that they are not showing symptoms. So the leadership role is very important because they need to being present and provide support for the staff. And then also there's always when you go to certain certain areas, there will be a question, and so the leadership team will collaborate with other patient care areas to ensure there is understanding and the information we receive is the same. We The behavioral reinforcement is also a big like leadership plays major role in behavioral reinforcement to make sure that social distancing is maintained in the work unit. We used to have huddle pre-COVID uh, at the beginning of each shift, and but because of COVID, we stopped that. We do everything for the to maintain in order to maintain that social distancing. And what we do, we provide our huddle via email or our Skype communication system, and to make sure that universal masking is followed at all time, to make sure people are not putting the mask below their nose. We need to make sure that their mouths and nose are always covered. And then we also have a responsibility in terms of making sure we have the appropriate staffing. When it's not just only the number, we need to make sure that we have a trained staff in the area where a patient need comes, to make sure that our staff able to respond to the need of the patient. And also training, communicating with other areas to limit the number of individuals on COVID-19 designated areas. We had in the ICUs one designated area, so instead of rotating our staff, we put a designated staff, so they are the one who usually go there. And if one of them is, for example, out for a reason, and then we have another trained staff from another area who can come and cover. So that way we make sure that we have a continuous coverage, and also limit the chance for exposure at the same time. And change management is a big thing in this chaotic situation, as because we need to make sure that our staff knows, they are aware of what's going on. And then because processes change is difficult for a lot of people, so we need to create that desire and acceptance for the change, and to make sure that we provided the training and to ensure that everyone is having the necessary knowledge. And then we also do assessment. We go out on the floor, we see how the process are, how the new process is different from the previous one. And if there is any gap, we try to get those feedback from our staff. And we ensure, we reinforce the implementation by making sure that everybody's following the new process. So the outcome of all this changes to the workload, even if I don't like it to say it's a new normal, is wearing a mask and eye shield all the time has become a new normal for us. Trusting the new process in compliance to the guideline also, we have a very good response in terms of following, being compliant to all the guidelines. The dawning on and off process takes time, and by transferring the work assignments to the nursing, it reduced the overall workload for us. And so that's so our staff has a time to don on and off their PPE properly, so they're not rushing. Just to give you some data, arterial line in the ICU in the general area, it reduced by 50%. Our capillary collection in the ICUs and general areas reduced to 2%, because we no longer do point of care glucose, because most of our capillary collection were for a point of glucose testing. In the ED, because now we are testing more more patients point of care glucose, our capillary collection increased by 270%. We no longer do IV placement, so our takes only focus on the blood draw process. Venous line collection, assisted line collects, and ED, it increased because now our trauma and those COVID positive aerosol generating areas, our nursing staff are doing the collection for us. So there's no major change in general regarding vein puncture and arterial puncture in all areas. Here, what you will see is also how not only on our collection part of it, also our point of care testing has reduced post-COVID for especially for glucose from almost from 8,000, it came to 550, it dropped to 550. And in general, we don't see that much different. For the CG4, which is the CG4 cartridge lactate, we use it for lactate. And it looked like there's an increase post-COVID. And for the other testing, there's no much change in general. So if you have any questions, I'll check. Okay.
Thank you, Martha. As she just mentioned, if you do have any questions, please be sure to select the Q&A icon on the Zoom to submit your questions down at the bottom.
So what are you using to disinfect draw stations between patients? For now, I think Oxivir, and we use different like disinfected supplies provided by Mayo, and the one of them is the Oxivir, and we make sure that our staff disinfect their collection cart and before they leave the patient room. Our phlebotomists do not collect COVID testing. We do not collect swab because we're not trained on that part. The third question is, okay, regarding blood collection for blood bank testing for COVID positive patients, do you allow the same phlebotomist to collect the second tube for blood type at the same time the first tube is collected for the blood type? Or does a second phlebotomist need to collect the type for the second type? Okay, our process in terms of using the LIS system changed 2 years ago. And based on, because we use a close patient identification system, and that eliminates the need for a second blood draw for transfusion or blood banking test samples. So we use our LIS system, with one sample for each blood bank collection. But if we do it manually, and that's when we are required for a second take to go and collect it. And we usually, because I have not seen, unless we have a big outage, I have not seen where we have to do a manual entry in our LI system, and that requires us a second tube to be collected. But in that case, if that happened, a second take will go and collect the COVID positive patients. And just to give you the background, because we required the masking all the time, and the universal masking and the wearing eye shield or eye face shield help our staff to confidently go to this patient positive rooms. And it was uh, so it was not a problem even for a second tech to go to this patient room and draw the labs. Okay, how are you handling employee call-ins? So our strategy was to train our staff in all areas. So we anticipate everyday employee call-ins, whether COVID time, pre-COVID time, still now. So we have a system that will allow to call for help from other areas, and to make sure that everybody has the skill set to go and help on other areas, and that become a help for us. So will point of care glucose for phlebotomists return after COVID-19? Based on the outcome for the patient care, I don't think it will come back to phlebotomists, because it's easier for the nurses. They are already there. Whenever they need the testing to be done, they can do it instead of waiting for another for a phlebotomist from another area to come and collect it. So did I understand you that you are using nursing staff as much as possible before using a phlebotomist? Um, so the reason we are utilizing the nursing staff is because this is a unique situation. We want to minimize the exposure, and our nursing staff in the ICU, they are already in the patient room, and so we want to utilize them. And also, it's not only this that come from phlebotomy area, it came also from the nursing as a collaboration effort to reduce exposure, not only for phlebotomists, for everyone. So that's a common collaboration that came. So what does ADCAR stand for? ADCAR stand for is awareness, desire, knowledge, assessment, and I forgot that. Reinforce. So that's what ADCAR stand for, and it's the acronym commonly used for change management. How are you handling staffing shortage with COVID exposure? Um, just like how I explained earlier, we train almost everybody everywhere, and also we call for other areas to come and help. We have the two hospitals, we have the Methodist and also the St. Mary's. And if we if we have a shortage, we can ask the staff from Methodist to come to St. Mary's, and the same that way. And our overall, our volume was not as it was pre-COVID during the COVID time. And now post-COVID, we are going back up, and we even have some staff who are on furlough because we don't have that much of the need for it, because our volume was very low. Yeah, so collecting outpatient COVID suspect for blood and nasal swab, we can use the modified droplet precaution PPE, surgical mask plus face mask, no gown. I just, for our modified droplets patient, we always require gown. So that was a requirement if you follow the instruction on that modified droplet isolation. And I also checked with our outpatient colleagues, and when they get, for example, when the patients are coming for blood draw, they get tested. If they show symptom, what they do is, if they check with a doctor and their doctor says yes, they need this blood to be drawn, what they do is they wear full PPE, their gown, their face shield, and their surgical mask. And then that's how they go and draw the patient. Whether inpatient, outpatient, the PPE requirement is the same for any COVID suspected patients. So are you disinfecting between every clinic draw patient? What is the dwell time for cleaners, and has it slowed down your morning process? Is there a safe way to clean between every patient in a timely manner? So yes, we require our supply cart to be cleaned between every patient draw. And that has been our process as far as I know. And when COVID come, that does not change. And our infectious disease prevention team, they ensure that our cleaning method is safe, and we not and then the time we follow what's on the time listed on the disinfectants. The majority of the time we use the 1 minute. That was the contact time it needs. So it has not slowed us that much. But when we have a shortage with that, we use another disinfect supplies, which require 2 minutes, 3 minutes. Again, when we go from patient room, you have the time, and our staff are trained on each different disinfectant and the time, and we always make sure we provide that information to them. Are you monitoring RN collected specimen? If so, what? Reject, shortage, immobilized. Okay, so we already have RN assisted collection process already, because some if it is a venous line collection, and if it is an open system, we don't collect it. The RN would do the collection. We supervise the collection process. And so again, when the RNs do the collection in this COVID positive patient room, we are still monitoring them through the door to make sure that every process is maintained. Our quality person is looking at the data for rejection, shortage, and hemolyzed. I don't have the data right now to give you on that, but from the collection standpoint, our phlebotomist is responsible and monitor the RN collecting the specimen.
We are at the top of the hour here, Martha, so thank you very much. And I do realize that there are several questions that we weren't able to get to today. So I'd like to thank you all for participating in today's phlebotomy webinar. If you do have additional questions or we didn't get to yours, please indicate them on your evaluation that will be forwarded to you here shortly. Note that laboratory credit is extended for this program, and upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Please visit the education website for more information on upcoming education offerings and a list of upcoming phlebotomy webinars. The next webinar will be on November 18th from 11 a.m. to 12 p.m. Central Time on quality metrics. Thank you again for joining us for today's webinar, and have a great day.